Nitin,
Hello, hi Riaz, how are you?
Nitin, can you do one thing for me? Can you just take on this moderation session? I'll just join. Give me 5-10 minutes. Can you do this?
Sure, sure. What I have to do?
Nothing. Just moderate. Just you have to go through the slides and just ask the questions. Some patient, some serious patient is outside. One or two patients. If you can give me some moderate, I will be there. I'll just finish those, and uh,
Oh, I can do that, but who is the panelist? Am I?
me and other are attendees.
Okay.
We are live, sir.
Sure. Hello.
Yes, sir. You can start.
Yeah, I can start. And just a request. On my behalf, Nitin is taking part. I will be just logging in. Give me 5 minutes. Nitin is taking. Can you just make Nitin live?
Sure, sir. Sure.
Sure.
So just to introduce you all, following Pfizer's long tradition of promoting science and providing a platform for interactive, insightful discussions, today we gathered here to listen, discuss, and learn about relapse and refractory B-cell ALL. So today we have our esteemed faculty, Dr. Riaz Ahmed, Director Hemato-Oncology at Max Saket, Dr. Isa Kaul, Associate Director, Department of Hematology and BMT at Max Vaishali, Dr. Nitin Gupta, Senior Consultant, Clinical Hematology at Sir Gangaram Hospital. So over to you, Nitin, sir. Sir, I think you are on mute, sir.
Yeah. Just a second. I'll just make it full screen. And am I audible?
Yes, very much, sir.
So you can say next slide. So I'll change the slide.
Just a second here. Okay. Oh, it is not going here. Full screen. Okay. Now, okay. Good. So good evening to all, and thank you, Pfizer. Thank you, Riaz, and thank you, Dr. Isha, to be here. And thank you, Pfizer, again for giving us this opportunity to discuss about the newest topic in management of B-cell ALL. So, inotuzumab, we know the topic is transforming the treatment paradigm for patients with relapsed refractory adult B-cell ALL. Next slide, please. So these are my disclaimer. So slides and have been provided by Pfizer. And next slide. So the expert with us is Dr. Isha Kaul now.
Sir, आप और मैं ही है.
So I'm I am asking the question now. So you have to repeat. So how many patients do you see for adult ALL in a year? So again, it will be a wild guess only. And if you have a concrete data, so please show that. As far as I can say, I don't have any much data, but yes, if I say in the last maybe 8 years in Gangaram Hospital, maybe every year I would say adult ALL we see around 10-12 patients. That's it. So what is the proportion of relapsed refractory adult ALL in your setting? In my setting, I would say relapsed refractory. So yes, unfortunately around 30 to 40% people will relapse at some point of time, and mostly these are BALLs. TALL is, as we know, it is lesser common variety of adult ALL, 10-20% of patients. So 80% of time it is BALL. So yes, we maybe see maybe 2 or 3 patients with relapsed refractory adult ALL every year. What is your experience, Dr. Isha? Dr. Isha, are you around?
So she has lost connection.
Oh, okay.
Yeah.
So just let us wait for 2 minutes for her to join.
Okay, sir.
Able to.
Yes. Doctor has joined, sir.
Okay.
Hello.
Hi, Dr. Isha. So I think we lost you in between. So the question to you
Hello.
would be, how many patients of adult ALL you see in a year in your institute, and what are the proportion of patients with
Hello.
refractory ALLs? Hello, can you hear us, Dr. Isha?
Hello.
Hello, Dr. Isha, are you around?
Hello. Can you hear me?
Yes, we can hear you. There is some problem here. Next slide. Previous slide. Dr. Isha, can you hear me now? Please go to the next slide. So in this study, published in Clinical Lymphoma, Myeloma and Leukemia 2020, it was a systemic review of burden and treatment pattern of adult and adolescent acute lymphoblastic leukemia in India, comprehending the challenges in an emerging economy. So the results showed that the proportion of ALL among adult patients diagnosed with acute leukemia at reporting institution from 16 Indian study ranged from 7.3 to 57.8%. So it is a big variation. The complete
Hi,
remission rate and
Dr.
median
Nitin, can you hear me?
survival. Hi, Dr. Isha, I can hear you.
Okay, okay. Sorry,
Okay.
something
Yeah,
happened.
so I can
Yeah,
understand.
so I think in answer to your previous question, the numbers I think would be the same, maybe 1 to 2 patients in a month. Some months will be 1, some months maybe 2.
Right.
So especially if you count like AYA also in adult, then the number will be slightly higher, I think, depending on where you draw the definition of adult, if it's 15 or 18 or 20, like that. So I will say around 1 to 2 per month.
Right, right. So in this study, we can see that it is a systemic review from India of 16 centers, and patients diagnosed with acute lymphoblastic leukemia. They found that the complete remission rates and median overall survival for these protocol range from 46% to 91%, and 7 to 46 month was median survival. So there is a wide variation. So the range is huge here, and overall relapse rates were 24% to 57% within median time to 9 to 24 months, and with the bone marrow the most frequent site of relapse. So I think there is a variation because of the different institutes involved here, and some may be catering a particular population, maybe more pediatric population, some may be um, uh, difficult, rather say elderly population. So there was a wide variation in the practices and of course the results. Next slide, please. So we know that the cure rate for adults, ALL, decrease with age. So pediatric ALL is a big success story. We are all aware that most of the children in these days diagnosed with acute lymphoblastic leukemia will be cured of their disease. Especially true for the patients who are between 1 to 10 years of age. But yes, as the age increases, the outcome in the, especially in the adults and elderly, are not that rewarding. And we can see in these Kaplan-Meier survival curve, proportion of the patients as the age advances, the outcome get worse with age. So on the right hand side, if we see the worst will be patient who are middle-aged and elderly people compared to the younger people. And of course, the outcome are improving with the age, we can see as in the left hand slide. With with the advent of the treatment, so with the newer therapies, outcomes are getting better and better. Next slide. So this is a very kind of basic question. What are the diagnostic tests used in establishing a diagnosis of ALL, and is CD22 a part of flow cytometry panel in your institution associated laboratory? So again, I will be answering it first, and so we do a flow cytometry at diagnosis, we do cytogenetic at diagnosis, we do PCR for commonly detected mutations in B-cell ALL, and including, of course, BCR-ABL mutation analysis by PCR. And we do, of course, flow cytometry nowadays involves a CD22 as a part of workup. So, Dr. Isha, any difference from this one?
No, it's the same. We have been using CD22 ever since inotuzumab came around. We have discussed with the lab, and now it's standard part of the diagnostic panel for our ALL. And the other question about diagnostic is that this we do standard, so flow, cytogenetics, and a molecular panel. The depth of the molecular panel, I think, is something in consideration, because now we have more advanced panels, especially for TALL. There are newer translocations, and there are pH-like is another considerations, which is sometimes not considered, included in basic translocation panels. So that is a question that we as a center are struggling with. We do want to do a more exhaustive molecular panel for all ALL patients, the way we do for AML, but cost is a little bit of an issue. Ideally, we would want to do more exhaustive, but at least we do 4-5 standard translocations we do.
Right, very well said. So again,
so Nitin, do we use CD22 in everyone, means pediatric, adult, upfront also?
CD22?
Upfront, yes.
I think it is because I'm not treating here pediatric patients, but in our laboratory is the same, so they do CD22 include for every patient.
And are we offering inotuzumab upfront? Means elderly, yes, but pediatric, are we changing? Means I'm just asking.
Again, I'm not the right person, so I am not using it as a upfront therapy. Of course, not in the pediatric patient. Of course, I don't see much. And Dr. Isha.
So my thought on this, I think the data is very early. We just had some data from ASH in December 2022. My thought in terms of incorporating that in practice is that, for now, for pediatric, we have good results. Pediatric or AYA, actually. I think I'll talk more of AYA. Adults, in older adults, upfront use of inotuzumab, there is more mature data. We do offer it, but because of cost constraints, a lot of people, majority people are not able to manage. But it's part of, the choices when we discuss. For otherwise, I would say that the decision of when somebody is MRD positive, at a time point after phase 1 or phase 2, now with the newer data, if somebody is hesitating for transplant, there is data that you can incorporate newer therapies and still achieve good outcomes. So I think for intensification of treatment, not in relapse while the patient is still in remission, but MRD positive, that is one subpopulation in which I think I will seriously start thinking about inotuzumab in that setting, instead of using high risk blocks or hyper CVAD or flag. So if you are going to intensify treatment, then at that point incorporating this is something I'll give serious consideration to.
So elderlies and relapsed, yes, we may consider. I think so, upfront, but pediatric and adults, I'm not very sure. Sure. Anyway, please proceed. Thanks.
No, Riaz, you can resume now. You are around, so
No. Please continue.
please go ahead.
No. I'm listening to your talk. Please.
Okay, perfect. Okay. So again, so this part has been discussed now, and next slide, please. Previous one, please. Okay, next one. Okay. So that has been discussed. Next slide. Again, a very difficult question. How many percentage of patient relapse within first year of diagnosis of B-cell ALL? And what is the most common site for relapse in your practice? So my take will be that the most common site of relapse is bone marrow, or a combined bone marrow as CNS relapse. Isolated CNS relapse we see less often these days. And how many percentage? Again, it will be a guess only. So as I said in the beginning, unfortunately, most of the relapses happen within first year of diagnosis or first year of maintenance therapy. So maybe 20% will relapse in my hospital setting. Dr. Riaz and Dr. Isha, please give your views. Dr. Riaz, Dr. Isha, can you hear us?
So yeah, like you said, most of the relapses that we see are in maintenance phase. If somebody is relapsing within first year, that means they're either, essentially primary refractory, that they're relapsing while they're on the initial therapy, or around maybe 20%, and then another maintenance, like second half of point.
Maintenance.
Nitin, I think so. 20% of the patient of if we divide in elderlies, 20% or 30% must be relapsing in first 20-30%. In maybe less than 40 years, 15% of the patient relapses in pediatric patients. When if whatever numbers we had in Rajiv Gandhi, they were a little less. Either they were refractory or they used to do very well. So it was very, because the number was small with us, it was, I can't comment that we were representative. But it was 15-20%, you can say maximum 30% in the elderlies. They used to relapse within 1 year. 30% of them.
Right. So again, very good. Next slide, please. So the problem here is the poor prognosis of relapsed ALL in adults, as shown in these studies, UK MRC and LALA 94 study. We can see if the adult ALL, if they relapses, so the overall survival will be dismal. It may be 5% in the LALA study, and UK MRC will be close to that, maybe less than 5 or 10% in different age groups. So the outcome of relapsed ALL is very poor, and there is need to increase, improve the survival of these patients. So I think my personal experience is also the same before the availability of the newer agents. And if, of course, if you are not able to bring the disease under remission and do allogeneic transplant for them, the chances of cure are poor. And I think if I analyze my data, we are able hardly, I would say in so many years, hardly did a transplant for elderly relapsed ALL. And not because that the transplant option was not available, but we were not able to bring the disease under control, and probably some of them died in the process of achieving the remission. Dr. Riaz, what is your take? And Dr. Isha? Maybe next slide, please. So as I was saying that the survival is dependent upon the response to the salvage therapy. So our first um, target is to achieve a remission and then do a transplant. And the patient, as we can see in these studies, the patient who can achieve a complete remission with the second line therapy or salvage treatment, they have a better survival compared to the patient who are not. And the patient who can undergo a transplant, of course, many of them, around 30 to 40% of them, will be cured, while the patient without a transplant, survival will be close to 0%. Next slide, please. So if we see the NCCN guideline version, 2020, of course, little older, but yes, still relevant. We don't have much newer therapies in the ALL management other than blinatumomab and inotuzumab and CAR T cell therapy, of course. And if we see the pH positive ALL, of course, we do treatment along with TKI and chemotherapy. But in the pH negative ALLs, which are a rather more difficult set of patients nowadays, because we don't have any targeted therapy in those patients. So um, uh, but yes, once the patient relapses, then we have the availability of these agents, inotuzumab and blinatumomab and CAR T cell therapy. But yes, upfront, I think it has not yet entered into the clinical practice, but yes, once we have the mature data about the use of these agents in upfront therapy, I think the outcome will improve. Next slide. So until now, transplant is the only curative option available to these relapsed patients. If we do transplant, median overall survival is significantly better, 14.7 months versus 2.7 months, as per this article from Blood 2012. Next slide. So what is the goal of treatment in adult relapsed refractory ALL in your opinion? So Dr. Isha, if you can take this question, and Dr. Riaz.
I think when we are talking of adult, if adult, relatively younger adult patient, we would definitely want to go for curative therapy. So, if I have a 30-year-old, 35-year-old, 40-year-old relapsed refractory, principally we would still want to go for a treatment strategy with the aim of cure. But once we start getting into, I would say, even 50s and 60s, then it by and large becomes a little unrealistic, because the kind of intensity that it will require, it's really difficult for older adults to tolerate. So I think within adults we have to make a distinction of younger.
So my take in relapsed refractory BLL, whatever we do, we are only able to salvage 10% of the patient, whatever we do. So select out those patients who can be transplant eligible, transplant them. And if the general condition is not there, they are just for palliation. Whatever we may do, the long-term data is not more than 10-15% in long term. Either you transplant or not transplant. If you don't transplant, it's only 6-7 months. If we do transplant, 10% of the patient will be able to salvage.
So Dr. Riaz, what is the upper age limit of your patient for a transplant in adult ALL?
See, we have done out 68 years also, but 65 is the, if fit 65, I'll be able to do that.
Okay, fit, of course, fitness is very
fitness, yes, fitness is
fitness,
no comorbidities.
You have been done, and
68 we have done. In RGCA, we did 68-year-old also.
Right. So very good. And so I think everybody is.
But that is not the norm. Maximum patient of more than 60, they don't do well. see, I should not get away with this. Most of the patients who do well are less than 60 years of age. So less than 60, their performance status and whatever, it's much better. Their outcome is much better. The best result in relapsed refractory cases is whatever patients we all of relapsed refractory post-transplant who are surviving are less than 40 years of age. But for few 2 years, 3 years, you can say PFS are there of between 50 to 60. Less than 40, 20 to 40 is the maximum. Whatever survivor we have in post-transplant, ALL relapse post-transplant we have is between 20 to 40 years of age.
Okay. Next slide, please.
Would we make a distinction here between relapsed and relapsed refractory? Like if it is truly relapsed refractory, then that's really the most dismal one. But if it is a relapse in the era of our ability to salvage with newer targeted therapies, I think if it is sensitive and you are able to put them in good quality deep remission, maybe futuristically the numbers will go up a little bit. I'm cautiously optimistic.
Right. So I think everybody is on the same page here. So MRD negativities are one of the goal. Of course, we may have little bit disagreement here also, but yes, at least a complete remission is required, and MRD negative is the best kind of remission we can get. Next slide, please. Next. So inotuzumab achieves a higher rate of complete remission and MRD negativity among responders versus standard chemotherapy. Right. So we can see as in these inotuzumab trial, innovate trial rather. So compared to the standard of care, which included, I think, the salvage second line different chemotherapies, CR rate was 74% versus 31%. MRD negativity 76% and 38%. So it is a very significant and kind of unbelievable responses we see with inotuzumab compared to the standard second line therapies. And we all know, personally, if I can speak my experience with chemotherapy as a second line, like a hyper CVAD kind of protocol, is not that good. Of course, rather it is quite disappointing. Maybe 40 to 50% of time they will get into a remission, and of course MRD negativity is even lesser. Next slide, please. Okay, next slide. And if we give inotuzumab as seen in the innovate trials, so the patients who are able to get 2 cycles of inotuzumab, MRD negativity is achieved in most of the responders. So after cycle 1, MRD negativity is 45%, and after cycle 2 it is 87%. And after cycle 3 and 4 it is almost 100%.
So if we are using inotuzumab based protocols, should we commit to doing 2 cycles, or should we just look after 1 cycle and see if they are negative and not do 2 cycles? Like what? How many times should we be testing practically? That's something that I am still struggling with in my mind, that we just commit that we are going to give each cycle. Any thoughts, Dr. Nitin or Dr. Riaz, about how frequently we should be assessing the disease status in inotuzumab based protocols?
I think we should do after 1 cycle, and if 1 cycle is negative, then we don't need to repeat it. If 1 is positive, then we need to repeat after cycle 2. So that has been my practice, and Dr. Riaz? I think we lost him somewhere.
No, sir, he's there.
Okay.
He's on mute. Doctor, please unmute yourself.
Next slide, please. MRD negativity was associated with an overall survival benefit in patients treated with inotuzumab. So in the left hand side, overall survival in patients treated with inotuzumab who were MRD negative versus MRD positive. The survival is better as expected in MRD negative patients. And on the right hand side is PFS. So both the things are better in the patients who were able to achieve MRD negativity. Next slide, please. Survival has improved in MRD negative patients treated with inotuzumab and was even greater in the first salvage. So rather than using inotuzumab late in the treatment, say after more than first relapse, so outcome will be better if we try to use it in the first relapse. Next slide. And if we are able to combine both the things, that achieving the MRD negativity and patient then undergoes a transplant, so that is associated with the best survival. So median overall survival was 19 months in MRD negative patient who underwent transplant versus 6.3 months in MRD positive patient who did not receive a transplant. So one extreme is MRD negative undergoes transplant, so the outcome is very encouraging, while MRD positive patient, of course, they are supposed to do bad. So, and of course, if they are not transplanted, outcome is dismal. Next slide, please. Coming to the toxicity of this agent, inotuzumab is generally well tolerated and has a manageable safety profile compared with the standard of care. So the adverse reactions we commonly see in these patients is one of the thing is infections. Even the infections are less in the patient who receive this product compared to the patient who achieve this standard salvage chemotherapy. Blood count abnormalities, of course, it has one, but it is lesser than the standard of care. Significant difference if I see in which I think everything is less in patient who gets this treatment compared to the standard of care. So no toxicity, which is little bit, if we see the biochemical alteration, especially the transaminases and GGT ALP increase, which is more in inotuzumab compared to standard of care. Next slide, please. So the question here is the best treatment in first salvage status and high disease burden patients. So what do you choose? Dr. Isha, Dr. Riaz, please give your inputs. What is your first salvage therapy? And the patient who have high disease burden, so lot of blasts in the peripheral blood or lymph nodes or hepatosplenomegaly. Do you prefer a salvage chemotherapy or inotuzumab?
If I'm targeting to take the patient to transplant, then I would like to incorporate inotuzumab, because that realistically gives a chance of putting a patient into CR, MRD negativity, and then there is benefit of transplant.
Right.
But if the situation is such that transplant does not look realistic for whatever reason, I would possibly just use some, and palliative low intensity treatments just to keep some kind of control and not go very intense. But if I'm really targeting transplant, I think it is better to incorporate some novel agent. Otherwise, your chances of taking the patient to transplant are very, very low, because it's very difficult to put relapsed ALL into CR2, deep CR2.
Very well said. So again, we actually, of course, need to make a shift this, because some of the people I have seen even recently, they are using second line chemotherapies to bring the disease under control. But yes, we have the now data and of course some experience with the inotuzumab, which gives us a kind of more safety, of course, efficacy as well as safety in the bringing the disease under remission, so that patient can undergo transplant as well. So very well said. Next is the Dr. Riaz, what is your opinion?
Yeah, MRD negativity is the best way in relapse case, but I don't know whether we are able to achieve with that. We aim for those patients who are going for transplant. For those who are not, those who are old and we have just a transplant is not an option, then I think so. Just prolongation of life is, that's inotuzumab is the best way. Just continue inotuzumab if they are able to take, or some. Okay, we are using sometimes when they are not. Sometimes venetoclax, some low dose of venetoclax with mini CVAD, and in the type of protocol we keep on giving for 4 to 5 cycles, 6 cycles. Then maintenance also we'll try to. So few patients we are able to do. And elderlies, those who are not affording inotuzumab, I don't think so. We have got long-term patients. Generally, we have used for younger ones who are planning for transplant.
Right, maybe 2 cycles also.
Yeah, 2 cycles, 3 cycles, whatever, and give them time for 1.5 2 months. Stable type of disease before you're taking for transplant.
Next slide. So I think this part has been discussed. So the best therapy nowadays will be inotuzumab if it is offered at first salvage therapy. And of course, as Dr. Riaz and Dr. Isha has said, that need to select the patient carefully. And I think the best, this agent will be best offered to the patients who are a potential transplant candidate. Next slide, please.
So here I have a little bit of a question. So if a CD19 CAR becomes realistically available, now all this is happening. There are a couple of centers that are doing, more centers are. Would that change the practice in any way? If we are at a time point where CD19 CAR is very easily, widely available, would that influence? What would be the order in which these would be done? My answer, I think, to that still would be that to use, because in adults, we still know that CAR-T in at least adult ALL is not curative. So if you still have to take them to transplant, I would say that I will still use inotuzumab based. If somehow blina becomes available, then in some situations blina might become an option. But I think this question we will be facing if CD19 CAR is more widely available, of choosing between these and CAR-T.
I think very pertinent question, and I think right now dilemma is less. We don't have the availability, but yes, it is going to arrive in future. And my take is, as you already mentioned, try to bring the disease with inotuzumab or blinatumomab into remission. Do a transplant to the patients who are able to undergo that. And if they are not able to undergo, then if probably these therapies will become lesser expensive with time, so we will be using them for a longer duration of time. And of course, the chemotherapy time is to go away now. And CAR T cell therapy, maybe as of now, I can say, because in the adults, the outcomes are not that encouraging as compared to the children's. So we will be As of now, I can say I will be using it after a transplant rather than before transplant. Dr. Riaz? Next slide, please. So again, the other parameters of survival are more pronounced in patients who are treated with inotuzumab in first salvage compared to the second salvage. So there may be many factors. We know that second salvage, the patient's condition or fitness deteriorates and the disease biology also changes. So better to use this treatment at the time of first relapse and do the transplant if possible. If they, and of course the outcome will be best if we do the transplant also fast, maybe after 2 cycles or so. Next slide, please. More patients proceeded to transplant with inotuzumab when treated in the first salvage. So again, very much understandable. The first goal is to bring the disease under control and then do transplant. So that happens with inotuzumab, and there is no question here. Next slide. So the safety incidents, safety issues, it is again, as I already mentioned, it is very much safe. And compared to the chemotherapies, actually it is safer in most regard, but yes, little bit issue of increased liver toxicity, especially if the patient undergoes a transplant. So the veno-occlusive disease or sinusoidal obstruction syndrome incidence increases, especially if it is used in the second salvage. So during study treatment follow-up, patient without transplant 1.8% versus 5.9%, and in the on following transplant 19% in first salvage versus 35% in salvage 2. So the, of course, the more the chemotherapies patient receives, chances of getting the VOD increases. Next slide, please. So what is your choice of treatment in cases of high burden disease? Again, I think the part has been already answered. It is inotuzumab. We don't have the other agent as of now. So of course, we are going away from the chemotherapy. So inotuzumab is the one. Next slide, please. So as shown in the INNOVATE study, the rates of complete remission and MRD negativity in inotuzumab treated patients were higher than with standard chemotherapy, irrespective of marrow blast count. So if blast count is high, so that should not stop us from using inotuzumab. Next slide. And the greater proportion of patients proceeded to transplant with inotuzumab compared with the chemotherapy, irrespective of the bone marrow blast count. Next slide. The overall survival is also improved by using inotuzumab, irrespective of the bone marrow blast count, whether there it is less than bone marrow 50% or more than 90% bone marrow blast. Survival in each of those category is better compared to the standard of care. Next slide. For patients with extramedullary disease or lymphoblastic lymphoma, outcome appeared improved with inotuzumab versus standard of care. However, sample sizes were very small. So here also inotuzumab fares better than the other therapies. Next slide. Safety profile issues in the patients who have high bone marrow blast counts. Again, it was similar. There was no difference from the patients who did not have high bone marrow blast count. Next slide. Treatment emergent adverse events and hematological laboratory abnormalities in the low bone marrow blast versus moderate bone marrow blast and high bone marrow blast count. So I could not see any kind of difference between the different treatments, including inotuzumab or standard of sorry, chemotherapy. Next slide. What is the long-term overall survival in your treatment setting? Very difficult question. So I will ask my experts here first, Dr. Riaz and Dr. Isha. What is the long-term overall survival in your treatment setting? So I think here we are asking relapsed refractory adult ALL overall survival.
ALL or relapsed refractory ALL?
I think both. You can answer both.
I think, I think there's a little bit of a bias because the really older people, who we sort of give only palliative treatment, they kind of don't even register in your mind after some time. The ones that you're actually trying to give some kind of aggressive treatment, I think if we go for those, it's probably 50% for adults, I will say more broadly. And for relapsed refractory, I think I will be able to remember each and every relapsed refractory patient who is alive. So it's not a big number because I can count them individually. So it's a very, very small number.
It's a very small, and again,
and the small number, I think, also is more in the last 2 years, when with the use of newer treatments. If I look back pre-COVID, there was hardly any.
Right. Dr. Riaz, are you around?
Yeah, same. It's very tough here. It's the same what Isha has. We used to bank on the means a lot of ALL relapsed ALL transplants, but I don't think so. More than 20% used to survive. Maximum 20%. That's the survival rate. Inotuzumab has made it little better. I don't know how much better. Data means equivalent number of patients who have received inotuzumab and undergone transplant, at least 3 years of follow-up. I think so it will take some time. The patient who was not given inotuzumab, who has undergone transplant, maximum, I can say 20% of the patient are alive more than 3 years or 5 years.
Right. So I think, of course, it is a kind of not a common scenario we see routinely. So need to, I think, gather data from many institutions and then collate it and then see how many of them are doing good or bad. So yes, but yes, the guess will be the same. Maybe hardly see any patients who had relapsed refractory ALL and then is surviving. So very few we can count upon on the fingers. Next slide, please. And of course, Innovate says that inotuzumab is making it better, and surviving patient has been followed for a minimum 2 years, and we can see follow-up after transplant 77 in the inotuzumab, 33 in the standard of care. So two-year probability of survival was higher with Ino versus standard of care, 10%. So that is again Western data also, but yes, with Ino it is 23%. So doesn't look a big difference, but it is quite significant difference actually. If you see statistically, it's significant. Next slide, please. Another curve showing a difference in survival. Patient who achieved complete remission but did not undergo a transplant. Made 7 versus 12 months. So a patient who were transplanted, it is a better survival. So as expected. Next slide, please. Oh, that is very important question here. So what is the most common adverse event in your experience, and what is the VOD incidence, and what are the strategies to minimize it? So 2 questions here. So Dr. Riaz.
VOD, and infections.
VOD. And what are the strategy you take to minimize it?
I think so. Best strategy is to delay the transplant as much as possible. Okay, minimum 1 month gap, and make sure your fluid intake balance is there. Is done on Lasix infusion during the transplant. That's the whole way. That's all, nothing much.
Okay, and anything do you use again like low molecular weight heparin or a different conditioning regimen you prefer to reduce the incidence?
No. We have not been using just fluid management, weight management, and if even use of defibrotide, I don't think so. We have used it commonly. That we are using in more in thalassemias rather than in ALL patient who has received that.
But I think there was some data to suggest that if you use double alkylator kind of regimen in conditioning, so the chances of VOD is much higher. Say, so better to avoid BUSI kind of conditioning, rather use something else. And of course, maybe we all be using it, and low molecular weight heparin and ursodeoxycholic acid. That's it. And as you said, proper fluid balance and use of diuretics. Dr. Isha?
Yeah, I think all the points that have already been discussed. My experience is also VOD. I think if you always see some VOD, how much VOD you see, how much you can control really depends on all the preventive strategies that we are now aware about. I think if we can stretch the time to closer to 6 weeks, a little bit longer, that is one important thing, just a hindsight, what we have looked is that the total amount of tuzumab dose that is received pre-transplant, to keep it as little as possible. So that is, if you use single agent inotuzumab versus if you use lower doses in combination with the chemotherapy, that reduces the total exposure to inotuzumab. So which is again less VOD if the total dose was less. So if your total dose before, if you've only gone into remission in one cycle, you've used 0.6 milligram per meter square and then 0.3 milligram per meter square, your total is less than 1. So if you're able to keep your total less than 1.5, less than 2, it's good. If they've seen a lot of inotuzumab, you are in big trouble. Azoles are a big problem. So we have used amphotericin-based prophylaxis in transplant for these patients. So I think those are the things which have, but you always see a little bit, at least, even if you've done everything, possibly, you see a little bit. Low dose TBI has been okay. One patient, with full TBI conditioning, it was okay, but still there was significant VOD. So because we did not know, but alkylators thing was known, but how to do TBI, because they're ALL patients, so you do want to incorporate TBI in the conditioning. So that, with full 1200 TBI, we've gotten into trouble.
Right. So next slide, please. So treatment emergent adverse events, more than 20% inotuzumab, any grade and grade 3, 4, and 5. So we can see in the inotuzumab versus standard of care on the right side, thrombocytopenia less, anemia less, leukopenia less, febrile neutropenia less, but OTPT increase is a bit more in inotuzumab. Next slide. Post-transplant VOD or SOS in the primary analysis and long-term follow-up, inotuzumab compared with the standard of care. Number of patients more in the inotuzumab group who proceeded to transplant, 48 versus 20, and VOD SOS in 21% inotuzumab and 5% in chemotherapy. And on long-term follow-up, 23% versus 9%. Median time to VOD after transplant with INO was 15 days versus 3, 14, and 38 days for 3 chemotherapy patients. So yes, initial 3 weeks are quite important for with respect to VOD. Next slide. 48% patient in inotuzumab arm proceeded to transplant, as did only 22% in chemotherapy arm. But yes, VOD was more. VOD SOS occurred in 3% of patient of during the study treatment, and 2 had pre-transplant, and 2 patients were more than 65. In the post-transplant follow-up, VOD SOS occurred in 23% of patient, and median time was 15 days. And of 5 of the 18 VOD events that occurred post-transplant were fatal. And 5 of 18 patient had pre-study transplant. All right, next slide. So in the multivariate analysis, post risk factors for post-transplant VOD and SOS were dual alkylator conditioning. 8 odds ratio is 8.6 here, and the pre-transplant bilirubin level more than upper limit of normal is another risk factor. Pre-transplant increased AST/ALT level. Again, a significant risk factor. Prior history of liver disease, of course, the odds ratio is 5.1 here. So again, a risk factor. Next slide. Incidence of VOD SOS by cycle after following the transplant. Cycle 1, if we do transplant after cycle 1, 8.3%, cycle 2, 18%, cycle 3, 23%, and after cycle 3, it significant, it almost doubles, 41%. So better to do transplant as early as feasible. Next slide. Recommendation for preventing and monitoring VOD in patient receiving inotuzumab. So some of the part has been already discussed by our experts, and I think we need to take all these measures. And then for the monitoring VOD, of course, we do take care at once the patient is admitted, do everything, their fluid checkup and their monitoring of liver function, enzymes, and so and so. Next slide, please. What is the burden of hospitalization for relapsed refractory ALL patients? In your practice, do you find treatment of relapsed refractory ALL patient with inotuzumab is cost effective compared to the other treatment option when offered in first salvage? So very important question. So the cost of this medicine is significant, and of course the cost of second line salvage therapy is also very high. So again, so panelists, please take this question. Is it cost effective to use inotuzumab versus the standard of the chemotherapy?
So I think the use of term cost effective in this scenario is very, it's, I don't know what to say about it. It's very costly. It is effective, but it's extremely costly. But it's, even if you can make the whole logic of, okay, your hospitalization is less, you'll need fewer number of therapies and all of that, but still it's very, very costly drug. In pediatric patients, your low weight patients, still the amount of drug comes out to be the number of vials you can sometimes make rational. But if you have a full adult 70 kg 75 kg, it's a supremely expensive drug, realistically, along with supportive care, transfusions, antibiotics, everything else that goes along with it. It is effective, but I don't know how to say that it is cost effective. I think cost is a very big challenge, especially in a reasonable sized adult, 60 70 kg adult, very expensive.
Yes. So I totally agree with you, Dr. Isha here. So very expensive drug, and Yes, but if, of course, we take into consideration the salvage part and hospitalization, if you are not needing hospitalization with this treatment, of course, I think the cost will come to be the same one. I think Dr. Riaz we have lost contact with him.
No, I'm still here.
Okay.
Don't worry.
Okay.
So, burden of hospitalization of relapsed refractory. See, it's very tough, painful also. As Aisha told, we are a little biased. If we know it's a palliative, we tend not to, and we tend to less, or the standard of care to them is different than where we are planning a salvage and transplant. Their standard of care is a little bit more. If inotuzumab is not there and we are giving chemotherapy, it's all inside the hospital. It's very intensive chemotherapy we have to give. But with inotuzumab, if we are able to give, I think so it's less. The complications rates are much lesser if the single agent we are using or with some low dose chemo, it's lesser. So that I can say. So I do favor inotuzumab if the finances is not a problem. I do favor in those patients who are going for transplant. Otherwise, those who are for palliation, it's all your take. It's an institution protocol, or you can make your own how much intensive you want to be.
Right. So very well said. And I think we just come to the last part of our talk here. Next slide, please. So the burden of hospitalization as seen in this study is the mean hospitalization days per patient month is 7.6 versus 18.4 days. And hospitalizations were less common with INO versus standard of care in cycle 2, 3, and 4 respectively. Next slide. So shown in the tabulated form here, and compared to the standard of care, inotuzumab patient require lesser hospitalization, and that can translate into cost effectiveness. Next slide. Coming to the ASH and EHA to 2021 updates. Next slide. In the real-world retrospective study from Germany and Italy, outcome of relapsed refractory acute lymphoblastic leukemia patients with extramedullary disease receiving inotuzumab. Next slide. So there were total number of patients here is 31, and if we see inotuzumab was received less than 2 cycles in most of 19 patients, 3 to 4 cycle in 7 patients, and 5 patients received more than 5 cycles. Next slide. And after 1 cycle, 41% of patients experienced this complete remission. The conclusion of this real-world study was that inotuzumab was effective treatment in patients with relapsed refractory extramedullary ALL and poor prognosis, including successful bridge to the transplant. Next slide. So updated study outcomes and safety. Overall survival 1 year is 53% and 2 years is 18%. In the patient who achieved a CR after inotuzumab, median survival was 10 months with no difference in relapse-free survival, regardless of whether an allotransplant was performed or not. So conclusion is treatment with inotuzumab is effective and promising approach in patients with relapsed refractory ALL with extramedullary disease. Allo-HSCT alone does not appear to be an effective consolidation approach for maintaining disease control. So that is quite interesting. Next slide. Next slide. So here we come to the end of this meeting, and please, Dr. Riaz, Dr. Isha, please give your concluding remark so we can just finish this. So what is your take?
I think my 2-3 takes is that it is, in a field which was otherwise very, very dismal, inotuzumab has brought in some hope. And there are a few more patients that we can save. I think 2-3 things we have to be a little sort of innovative and Indianize the way we use inotuzumab to manage the risk of VOD, as well as cost management wise. So if if people are doing slightly different things, it would be wonderful if we could share our experiences or pooled and publish our own sort of representation of how we are using inotuzumab. Maybe lower doses could also be effective. We don't know. So those of things are and if the cost of therapy could come down even by 20-25%, 30%, some kind of because the support system doesn't kick in till very late. You have to buy a lot before the support system kicks in. Then I think we will be able to, this use will be widespread. And then another area where I feel perhaps it can be used is in patients who are high risk, showing MRD positivity and unwilling for transplant. I think even usually if somebody is MRD positive, unwilling for transplant, we will say that they are destined to die. They are going to relapse, and perhaps in those people with incorporating novel agents, a subset of them could perhaps still be cured without going to transplant. So maybe for patients who are not willing or not eligible for transplant but have some high risk disease in even without a transplant, maybe I think there is some chances there in the future. So that is a subset I'm excited about.
Thanks, Nitin. Thanks a lot.
Sir, you are on mute, sir.
So I think now we conclude this meeting here, and just thanks Pfizer again, and please give your concluding remarks here.
Okay, thank you so much, sir, for the comprehensive presentation. So we apologize for the hurdles and the technical glitches in between, but it was an interactive meeting and very pertinent questions have been answered by esteemed faculties. I'm sure, sir, attendees must have enhanced their knowledge as well. Thank you once again, Dr. Riaz, Dr. Isha ma'am. Especially thanks to you, sir, Nitin sir, for being a savior today. Sir, we have more than 15 attendees attended live this session, and the link will be remain active for 24 hours. So thank you all the attendees and panelists for sparing your time and joining us. Thank you, sir.
Thank you, Pfizer. Thank you, Ishad, and thank you, Riaz, and goodbye to all.
Thank you, sir.
Thank you, sir. Bye.
Yeah, you can end the meeting. Thank you.